session on retinopathy of prematurity. I have with me a galaxy of stars who have been practicing retinopathy of prematurity for a long time with tremendous experience both in terms of patient care and academics and applications. So we have Dr. AIOC2022, who is like a household name in the field of retinopathy of prematurity, not just in this country but across the world. He has tremendous number of publications because of his kid drop study, and I proudly say that as an Indian we should all be proud that he is one of the participants of the panel of the organization which created the new international classification for ROP edition 3, which was published in 2021. He is one of the panelists from India. So Dr. AIOC2022 will kickstart the program with two talks back to back because Dr. Subhadra Jalali, who is supposed to give the first talk of this conference, is not available. So he will be covering both the subjects. That is on screening guidelines and how to examine an infant. It will be followed by Dr. Karodi Lahiri, who is from Mumbai, and she will be talking to us on laser photocoagulations for retinopathy of prematurity. And Dr. Parijat will cover anti-VEGF drugs in retinopathy of prematurity. Dr. Parijat is a professor of ophthalmology at RP Institute, Delhi. And Dr. Mangatram Dogra, the ex-professor of ophthalmology from PGH Chandigarh, who is not currently practicing in Chandigarh, will be talking on the role of surgery in the management of advanced retinopathy of prematurity. And I will top it up with a little bit of issues in ROP management towards the end. So without more ado, I will ask Dr. Anand to start the first session.
Thank you, sir. It's indeed an honor and a pleasure to be back at this instruction course after a gap of 2 years. I just remember when we started this course a few years ago, we were in hall, I don't know, S or D, and I still remember we spoke about ROP needs much more importance. Maybe someday we'll reach hall A. And I distinctly remember what you said. You said, I hope we never reach hall A because we should be able to nip the bud and treat the disease before it becomes so popular that we have to use hall A. I think that is the greatness and what you have set for all of us in this field. As I mentioned, I will be also covering what Dr. Subhadra Jalali is presenting, so it's going to be a sort of combined talk with both the newer classification, which we saw last year, and some screening and the telemedicine guidelines. As we speak, Government of India is actually revising the NMC bill. You all must be aware that till the 22nd of this month we are looking at some of that, and we might need to redefine how we are doing telemedicine screening in a couple of months. So in the international classification of ROP first came in 85, then 2005, then in 2021 for the first time they used the experience of collaborators outside the US and the UK. And the reason why they did that was very obvious. We, at least in India and middle income countries, are seeing diseases that the West has not seen, and we are sort of setting the tone on how the screening and the assessment should be done. So the subtype of the type of disease is where my talk is going to be. I'm going to heavily rely on just Indian literature and the Indian perspective. So the lowest resource income is where the problem is. A few practical things have been added into the classification. So we all knew that there was zone 2, and then there was zone 2 posterior, and now there is something called the notch. So zone 2 posterior is about 2 disc diameters from the edge of zone 1. Because zone 2 in the temporal quadrant is very large, we know that intuitively, and following up these babies, we know what is more severe and what is less severe. So zone 2 posterior is something that we might want to now club with the prognosis and the outcome of a zone 1. Also, this notch here in the left eye, everywhere else we have seen many times the disease is in zone 2, but then there's this small incursion going into zone 1. What do we call it? Do we call it zone 1 based on the old classification, or do we call it zone 2 because it's predominantly except there in zone 2? Well, now you have to call it zone 1, but in brackets you put in the word notch. This will help you relate to your colleagues if you are referring this baby out. It will also posterior zone 1 or zone half may be your indication. This has been there before, the 28 diopter lens being placed on the nasal edge of the optic disc on one side, and whatever you see in the view of that 28 diopter lens is where zone 1 ends. And I think that is so critical for us to see and diagnose zone 1, especially if we don't have a camera. And also, here's the irony. We are talking about two disc diameters from the center of the fovea. But the fovea itself is not developed in these babies who are 30, 31, 32 weeks as you screen them. So therein lies the pathology, and that's why the center of the macula can be used. Plus disease, we always know has been a conundrum. Less than 30% of experts apparently agreed with what is plus disease. And to make it worse, we had pre-plus disease. So this new classification identifies this and accepts this, that is now is going to be a gradient. There's going to be a gradient from completely no plus to an obviously there is plus. And this was actually done by a set of images that was given to all 35 of us who are part of this committee, and we had to sort of grade which one we thought was plus and no plus. And the ones where all of us agreed were plus were put right on top, and where all of us agreed there was no plus was put right below, and that was the gradient. Now, how is this important? Is this going to change the way we are going to call the disease? Unfortunately, not yet. Unfortunately, on paper, we'll still have to write plus, pre-plus, or no plus. But what happens because you've given yourself this gradient is A, you have given this some amount of variability, clinical, and B, very importantly, there is now a legal gray zone where you can actually claim that this may not be a plus disease a colleague may have missed or you may have picked up and so on. The next thing that we have been doing, and we have to change this nomenclature, is do not use no ROP or immature retina. Talk about where the blood vessels have reached. So it's going to be incomplete vascularization into, and then complete the sentence with till where you see the blood vessels. This is what has been recommended in the new classification. It's important we all use the same nomenclature. So this will be incomplete vascularization till zone 2. If you wish, zone 2 anterior to be more specific. Dr. Dogra's work actually, where he used to use the amount of immature retina in the temporal retina to predict which of these babies will actually eventually go on to developing disease. And we looked at that prospectively, and we know now that a large amount of immature retina in zone 1, that is, those are the babies who will develop ROP weeks later, compared to somebody whom you are screening for the first time, the blood vessels are already in zone 3. Both are still on paper immature retina, but how is it different? It is still where the blood vessels have reached, and that's why it's important to mention it. These stages, stage 1, 2, and 3 have not changed from the old classification, so I'm not going to spend time on it. Now, what is this we have here? For the first time in the international classification, we have the OCT. It's not that it's going to be used for diagnosis, but it's to understand the nuances of the disease, the pre-retinal membranes, the popcorns, the changing the foveal structure, and so on. If we have to spend a little time on this new classification, it is here. Aggressive posterior ROP has been changed now to aggressive ROP. The very fact that we dropped the word posterior, which means we now accept the fact that this disease is also seen anteriorly. And that has predominantly been the work from this country. So instead of looking at these definitions, which are available in the manuscript, let's look at pictures. So many of us have seen this kind of loopy, ghost vessels. You look at the blood vessels, they seem to be going to zone 2 anterior, but this disease is really, really zone 1 or even zone half. Because if you look at it, even without an angiogram, there's capillary non-perfusion, there's very severe plus, there's flat NVE, and if you look carefully, there are hemorrhages as well. So it's not just important to categorize or diagnose this, it's very, very important to describe this condition. Now, this is another type which would have probably been called hybrid, as Dr. Dogra described, where on some places there's fibrovascular proliferation, on other sides there's no vessels at all. So these vessels have not even gone to the fovea. What do you call it? So here you call it posterior zone 1. You can give it a subtype of hybrid, but in the older classification, but now you will just call it aggressive ROP. This is the other type, where the blood vessels seems to be going out. The fovea looks fairly, the capillaries seem to be working here, and believe me, when we did the angiogram for this baby, we proved that. But everything beyond the fovea, or even 1 disc diameter, has capillary non-perfusion. And these are the more occluded varieties. Many people on the Indian ROP Society group share images of what looks like vasculitis. They look like infective etiology, but in reality, it's nothing but aggressive ROP. And so even though we don't classically see NVD, and we hardly even see the blood vessels coming, bleeding happening on the NVE, it's important to recognize all these spectrums. Stage 4A and 4B has not changed, but what's new in this classification is the addition of the word E and T. E for exudation and T for traction. Now exudation often comes down with your treatment, be it laser or anti-VEGF. Traction usually does not come down, and these are the cases that might be surgically amenable. Stage 5 has now been changed a bit, so it's no longer open-closed funnel, it's 5A. Sorry for that, I think it's gone above. 5A, which is where you can see the disc, 5B where you cannot see the disc, the so-called closed funnel, and 5C when the anterior segment is also involved, as you can see in the picture below. There is not much emphasis given on the ultrasound findings of stage 5, which we used to do 20, 30 years back. Two new terms have been added, regression and reactivation. I'm going to go a little quick on this. A regression is either complete when the blood vessels reach the ora serrata, or incomplete if they stop short. Incomplete regression can happen after normally or more often after anti-VEGF. And therein comes in the new term, persistent avascular retina. Regression also can also regress in either vascular signs or non-vascular signs. And then comes the signs of regression. So please train your eyes on that. Persistent avascular retina, a very, very new important component. These are babies who would have been injected. The blood vessels reach from zone half to go to zone 2, and after that don't go anymore. And that's when we'll probably have to combine it with a laser therapy. The verdict is not out when you do that, but it's important to recognize that these are going to remain persistent avascular retina. Reactivation, the other new term, if you do a good and thorough laser, almost no baby is going to reactivate, although the incidence will tell you about 9%. Where it commonly happens is reactivation from after anti-VEGF. Here's a baby injected elsewhere. One eye you can clearly see had gone into a stage 5. The other eye looks innocuous, as though there was no disease, the blood vessels are just growing. But look at the angiogram and you see that the blood vessels have reached only zone 2 anterior. And this is 11 and a half months after injection. That's, I think, important to note. So monotherapy works in less than 30% of cases. So it's really important to follow up these babies for a very long time, and if you can't, then at least do the laser at some point. So combined therapy is probably going to be the way to go forward, although this classification is not going to talk about treatment. So documenting reactivation is really important. This volcanoretinal detachment is something that is very classically seen after aggressive ROP and even laser. The classification ends with the long-term sequelae. I've only highlighted the one we just spoke about. The others are fairly well known, and it's important to look at what happens at the posterior pole and in the periphery. This very busy table comes from the what is different in this classification compared to the others. I now move to my second part of the talk, which is screening, examination, and telemedicine. So in 2020, I think India was probably the first country to have a national guideline from the government sector. And we're very fortunate that the work started with the National Neonatology Forum, and then that moved on to what's now the RBSK guidelines. These are used not just in India, but a lot of the SAARC countries and other Southeast Asian countries as well. It's the pioneering work of a lot of the mentors that has seen this happen. So there is the RBSK guideline, and then there's the operational guidelines. They were separated by a year apart, and this is what we use because both of them are almost the same. This one tells you the role of every single beneficiary, be it the ophthalmologist, the pediatrician, the ASHA worker, the government, and so on. And these are more easily downloadable articles where we spoke about how to incorporate these guidelines into practice. So I've taken screenshots from these guidelines. These are currently what is going to be used both legally and clinically, and I think it's important to emphasize the word legally. So it's the 2-3-4 rule. So that is the 2 kilos at 34 weeks. That's the best way to remember it. And they have to be screened 30 days before life, or 30 din roshni ke. Or you can do at least one screening before discharge. And this is some work that we did in rural Karnataka, where we found that if you screen the baby at least once before discharge, the amount of enrollment increases by 8 times. So this is the clinical and legal caveat, 30 days. Now where do you do the screening? I think Dr. Dogra's group has shown that you can even treat these babies through an incubator wall with scratches. So why can't you then screen these babies? So delaying screening just because the baby is sick or incubator dependent is not something that we should advocate. We should convince our neonatology friends that it is safe to do the screening even if the baby is sick, because a delay is going to be very costly. Who is going to do the screening and where? As I mentioned very proudly that we are probably probably the first country at a national level to be allowed to allow ROP screening through a camera, and not only done by the ophthalmologist but by trained technicians as well. But the indirect ophthalmoscope and the 20 diopter lens is still our very good friend. You can either rotate the baby if you are standing in one place, or you can move around. Always face and depress the quadrant that you are opposite of. So if you are standing at 6 o'clock, examine 12 o'clock and so on. The cameras now have improved and have become low cost. Even as we speak in this conference, a newer one is almost being launched, which is probably going to be a mobile-based, although the validation is still pending. So these cameras, the Indian-based cameras, have really revolutionized the way we do the ROP screening. And where we do the screening, well, as long as the baby is sick and admitted in the NICU, please do it there. If you have invited the baby into your ophthal OPD, do it certainly, no doubt, for more stable babies, but do have the backup for taking care of these babies if they have apnea or bradycardia. So ideally, it should be done with some sort of neonatologist or anesthetist support. When you examine a baby, you just have to decide three things. Is this baby completely normal, mature retina? Does it need follow-up, which means incomplete or some form of ROP, or does it require treatment? So it's really as simple as that. You can only have three outcomes. And how long? Now this is really important legally. Do not discharge a baby from ROP screening before the baby has completed 40 weeks of postmenstrual age, because that's when the blood vessels are supposed to reach the ora serrata. If you examine this baby at around 36 weeks and find that there's immature retina, there's no ROP, don't write no ROP and send this baby away into the community. There have been very important mistakes which have now gone to court. Call this baby a month later. Make sure at least one exam is between 40 and 45 weeks. If you are of doubt of any finding, re-examine the baby a week or 2 weeks later. It's better to err on the side of one more examination than to miss this baby and have this baby turn blind. This is also from the operational guidelines on if you are using imaging, especially when you can discharge a baby. This is what we use in the Karnataka model. We've trained technicians to look at these images and decide when they need to follow up, when they need to be flagged for treatment, and when they're completely normal. So what are the best ways to document? Since in this legal scenario, documentation becomes so important, I would urge you all to have a duplicate of this form. So this is like a book we keep in every NICU. The top one is kept with us. The other one is left back in the NICU. They also have ability to follow back on their patients, and if they have inspections, it's very important that they have it, and you can put a carbon paper between the two. What's even more important is to hand over the mother or the family a card of your findings and make sure you have written the exact time and the date and the venue of your next screening. If you are screening in just one or two centers, you can even make a rubber stamp that goes copy-paste, but do sign under that form. It's going to become really important if you just write review back after 3 weeks and they don't show up to the place where you wanted, you do become liable. And liability is really important, and you have to once you take charge of this baby, it becomes yours until you have discharged that entire duty. Of course, if you are using image-based, it's much easier because all the database can be kept online. This has been a frequent question by a lot of colleagues, which is the ideal drop. So Oropen Plus, which the Arvind group used to make, the Oro Lab group, has unfortunately come under the DGCI ban, but it's being challenged, and I think we'll get this drop back soon. Until then, Propac P Semi is available commercially. I have more time, right? Since it's 2 talks. Right. And a couple of slides on what we did during COVID, and I'm very happy to mention that in our country, we did not stop ROP screening even in the first wave when we had no clue. And that's because as early as the last week of March, the Indian ROP Society came out with these guidelines, which were then used almost worldwide on how to modify the ROP screening guidelines so that we can still continue. So what was not changed? Who is going to be screened? That is the 2-3-4 rule. Again, to repeat, 2 kgs at 34 weeks. And where to screen also was not changed, except for the fact that some of these hospitals turned into COVID hospitals, so then you had to share the resource. When to screen and how often to screen was changed. This eventually became part of the AIOC guidelines, which are downloadable from the IGA. So simple things like this, the way we maintained social distancing, how the mother would keep the baby, walk away, the nurse would come and pick up the baby, and so on. Social distancing, all of this had to be defined. It seems now like a distant dream, perhaps, as we sit here without masks. But just about 24 months ago, we had no clue what we were dealing with, and we had frantic calls asking us, are you going to come next week to screen this baby or not? So here it is, the less than type 1 was the modification to the guidelines. That is, you can treat stage 2 with pre plus, stage 3 with no or early plus, and high risk for APROP but not yet full-fledged APROP. Giving it the sanction of a guideline from a society and putting it on the website also gives you some sort of a legal sanctity to do this. Of course, eventually it is now it's accepted for peer-reviewed publication, but we didn't wait that long. Because if we didn't have all this in place, then it might have been difficult for our colleagues to carry on. And amazing work has been done by the society members carrying on this at various levels. This is me trying to treat a COVID-positive baby almost in that full PPE suit, which we know now is probably overkill. But I'm looking at April 2020, just about 2 weeks since we went into the first national lockdown, and we had no clue. We needed government permission to move into this hospital to treat this baby as though we were entering a war zone. So despite all of that, I think our country has managed exceedingly well, and we've innovated the ways we are screening and treating. I was also asked to speak about the Kidra program or the telemedicine program. This slide has really not changed for the past 14 years because the process remains the same. We started off with 3 hospitals. We are now 136 hospitals in this financial year, the NICUs in Karnataka state. What we've done differently is to train non-ophthalmologists to take these images, upload them on a telemedicine platform, but more importantly, look at these images and decide which of these babies require treatment, require follow-up, and is completely normal. And the turnaround time is anywhere between 4 and 20 minutes. The treatment as far as possible is done outreach, and only babies who can come to the city are called in for the treatment. I'm going to end with some recent advances that our country has seen in all in-house Indian products. So this is the one we already spoke about. This is the MII camera that has come out from Agarwal et al., and they have published that. So this is a little bit dependent on the 20 diopter lens, so the field is a little bit restricted. The other one that comes from Yash's group in Ahmedabad is also based on the 20D, but it's a little more flexible. You place it on the hand, and Dr. Ali Banker has done a lot in innovating this. Just a few months ago, the Neo camera, which I just spoke about, now has the angio mode to it. I believe they have just received their CE approval, and they're applying for the FDA. And the clinical trial was completed in Bangalore, and we are going to publish that soon. Innovation in training, this luckily happened before COVID. So while COVID was going on, we were able to continue online training for a lot of technicians, male and female nurses in the rural outreach centers, not just in Karnataka, but elsewhere. I'm going to end with obviously the hot word that everyone's talking about is artificial intelligence. Again, some good work that's happening in India. The Pune group, Dr. Sucheta's, some others, and us in Bangalore. We are collaborating with biomedical engineers. This on top is a modified image of where a stage 2 and on the right an early stage 3 lies. And the below one, it just looks like a squiggle, but that's the software telling you within a couple of seconds that that's where the disease is, and more importantly telling you that the picture on the left is stage 2 and the picture on the right is stage 3. This is now in the early 90s as far as the sensitivity and specificity goes. There's a lot of work in progress, but it's important to integrate that with a telemedicine program. This has been a thesis of one of our DMD students using contrast sensitivity. Can you imagine that a baby this tiny during the first screening of ROP can be assessed for contrast, and the contrast value can help you predict which of these babies will have a higher risk for ROP and which of them will have a lower vision in the 3rd month and 6th month. Now that was intuitively wrong for me because I thought contrast was predominantly a macular function, and we were looking at a peripheral avascular retina, but clearly there's much more than meets the eye, and this was recently accepted in the PVST. And this is some work we're doing in Bangalore with our lab in MN. We are collecting tears during the first screening, and we are now analyzing the tears for some of these biomarkers, and we are now at a point where we're able to predict which of these babies will develop the disease weeks later. We are not yet at a point of detecting when that will be and whether that the baby will require treatment requiring disease. So at the end of the day, the work that we do in ROP, especially in the outreach, can only be measured in the amount of blind man years that we have saved. In our country, if we do about 10 states which have the highest ROP burden, we're going to be saving more than 700 crore rupees worth blindness every year. And that's the power of doing this program. And thank you so much for being here.
I would thank Dr. Anand for his excellent presentation about ROP. A word about something called as stage 0, what he mentioned about avascular avascular retina, no ROP. So even if there is no ROP, there is avascular retina, call it as a stage 0 ROP rather than no ROP. That makes it a little more easier. Can I request now Dr. Karobi to talk to us about laser photocoagulation? Dr. Karobi is a senior consultant who has been practicing ROP for many years in Mumbai, and she's an important pillar of ROP society of this country. Dr. Karobi has tremendous experience in both the surgical management and laser management of ROP patients. Dr. Karobi.
Thank you, sir, for the kind words, and thank you for having me on your IC. It means a lot to me. My topic today is lasers for ROP. Now, my topic would be a combination of something old, something new, and something fresh. So, let's go ahead with it. As by definition, ROP, as we know, is a potentially blinding proliferative disease. And one of the treatments, which I'm going to talk about, is the laser ablation of the avascular retina. Now, what is the rationale for laser treatment? VEGF is a stimulus for abnormal vessels which comes from the avascular retina, and to ablate the avascular retina between the ora and the ridge is to reduce the quantum of VEGF. Now, what happens is that there is a damage to the retinal pigment epithelium, leads to barrier resorption of subretinal fluid. Photocoagulation destroys the vasogenic cells and decreases the VEGF production, and destruction of the posterior ciliary non-perfusion areas, which is the source of VEGF, is how it acts. Now, cryo was a preferred method in the 90s when we started, because laser was just coming into being at that time. And once we started doing the laser, only for very specific indications, we would do cryotherapy. We would generally resort to a laser. Again, the lasers were the green laser and the diode laser. And this is now the current classification which tells you what kind of cases have to be treated. That is zone 1, any stage with plus disease, zone 1, stage 3 with or without plus disease, and zone 2, stage 2 or 3 with plus disease. Plus disease is defined as at least 2 clock hours of dilated retinal vessels, and the options of management are laser ablation of the retina or an anti-VEGF injection, or a combination of 2, or one preceding or following the other. So, as we know that this is delivered through LIO in a confluent pattern, and the plus disease shows regression first. About 90 to 95% attain favorable outcome if it is done at the right time. Now, treatment for this, how it compares with anti-VEGF, is that laser has always been termed as the gold standard treatment. It is reached quickly and predictably, needs experience of patients and sometimes GA if their child is a little bigger. And it's an important issue, that is the peripheral field loss is sometimes there, but you have to weigh the pros and cons of safety against whatever is a little problematic issue, and the complications could be an accidental foveal burn. Now, these are few of the topics where there is an evolution from cryo to laser, and frequency double laser is being used, and the diode laser is also being used. Favorable outcomes were seen to be about 97% as compared to 96.9% with the diode, and this is a study which was done by Mangat Dogra and group. And these are the cases of AIOC where you see a very fulminant persistent tunica vasculosa lentis, and this is the presence of plus. And on the right, you see another patient of AIOC where you get a proliferation on the nasal side. This is the kind of case which you are seeing very often these days, and these are cases where you have to carefully titrate and balance whether you would like to go ahead and do laser for these patients, or do you want to do a surgery right away. So we will deal with this topic a little later. And these are the other cases where out and out you know that this is a very fulminant form of disease, and this needs attention the day you see him, because generally we see them at 2 weeks or 3 weeks, and if a child has got any features of AIOC, you have to treat them as soon as possible. These are stages where you do not wait for it to progress through the natural progression of the stages of ROP, because they don't go through the stages of ROP. And a picture like this, where it is either a 360 degrees involvement, or you have a hybrid ROP, or you have a half-zone ROP. These are all very kind of red flashing signs where you know that you have to institute the treatment very dramatically, immediately, and very forcefully. Means you cannot have fermentation techniques of laser for these patients. You have to do very, 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 very strong treatment and effective treatment on these children over 2 or 3 sessions, or maybe more sometimes, to get your end result. Otherwise, it could lead to further progression. Now, what is the preparation is that you take a consent, you see that there are IV fluids which are there, a sugar pellet is generally clean, you check the vitals of the child, resuscitation measures are seen, and you dilate the baby. Dilatation, Anand has already told you what you do it with. The laser treatment, these are the parameters for the laser treatment, and this is generally, if an anesthetist standby is there, is good, but many times we do it in the outpatient without an anesthetist standby, and it has to be done over single or multiple sessions depending on what the condition warrants. And this is how you do the laser treatment. We are doing this in the outpatient, and this is one of my kind of techniques where I like to use a sugar pellet, because when you see this child is so comfortable and sucking on the sugar pellet, and initially they may cry a little when you start the laser, but then they allow you a very, very, very easy kind of treatment for the baby over your entire session of laser. This is something which I borrowed from Dr. Mangal Dogra, because he was the one who was the initiator of this, where he started treating babies through the incubator wall because the child couldn't be brought out, with very effective measures. And this was this which Anand has also shown you, where he's done through the incubator wall. Fantastic. And these were his patients, where he had treated them through the incubator wall, showing a good regression of the disease. Now, technical aspects means ROP can be done under topical anesthesia. There's no problem. There's a article by Jalali Subhadra and Dr. Azad. Now, additional treatment by laser treatment was applied to the avascular retina or the script areas in the following conditions. One, if there is an ROP persistence, that is the persistence of neovascularization or plus disease 2 weeks after primary treatment. If there is a ROP reactivation, that is return of neovascularization or plus disease after initial ROP regression. ROP progression, the progression to a more advanced stage. And fourth is an unresolved peripheral avascularity of zone 2 or 3 after primary intravitreal ranibizumab or bevacizumab. And these were the risk factors, that is gestational age, zone 1, half zone, posterior, this ROP. And you have to always look for systemic causes in these patients, because many times the reactivation or the reappearance may be as a result of systemic cause rather than a local cause. Now, in a patient like this, you see this area where there is persistence of flush, there is laser, and you see the persistence of an angry frond over there at the ridge. Now, this is a patient which you can't leave alone. This is a patient you have to treat immediately. And what are the forms of treatment can you offer? At the current moment, we would like to give an anti-VEGF, because that will work best towards decreasing that, and you can do a top-up laser. In such patients, you always look at the periphery and see if there are script areas, especially if the patient has not been yours, or even if it has been yours, because many times those script areas have to be treated to get a positive end result where your plus regresses and the disease quietens down. Now, this is extensively done laser. I mean laser where there is no scope for more laser. You've done laser posterior to the ridge also, and you see that large front at the area where the avascular area had originated. So there, again, anti-VEGF treatment, because when you give an anti-VEGF treatment, within a day you find a regression of the front, which is rather dramatic. Again, look for script areas. If there is something to be filled, fill it up, because it's better to be thorough and be free of any kind of headaches later on. These are certain articles which just are there to show the effect of combined laser and bevacizumab. This is another patient where an incomplete laser has been done, and there again you have to also anterior to that peripheral area, and this is how they avoid the areas where the tractions are there. And so you do a barrage technique, and this is a safe technique. It allows complete regression. Now this is following intravitreal bevacizumab, where you find an area which is still not vascularized, and there it is necessary to do laser to that area. So you can do laser posterior to, anterior to the ridge in cases of bevacizumab or ranibizumab or any other anti-VEGF, and anterior to it if you've done a laser first and still there is a kind of a recurrence or with an anti-VEGF injections. Now there is something called as crunching of the retina, which occurs after primary intravitreal injections of anti-VEGFs. There is, because if there is no RPE retinal adherence in the avascular vein, it is initiated by that, and when you see an effect like that, it is important to go in and quickly do the laser before it becomes too prolific and starts dragging on the retina. These are certain other articles which are there for posterior barrage, same things, outcome. And this is a comparison again of diag versus this. And fluorescent angiographic measures has been demonstrated by Dr. Anand, also gives you the areas of the non-perfusion areas, and this is important to laser those areas for a complete effect. Lasers for persistent zone 3 disease. Now this is an area which is like very ambiguous. You have to call the patient for frequent follow-ups, and if you feel that this is not getting vascularized, then around 45 to 55 weeks, just go ahead and laser it, because this is peripheral retina. It's not going to harm the patient, and at least you'll be free of the worry that sometime something might develop over there, which I'll show you shortly. And these are how it is done. These are modified techniques. There are certain laser-assisted, camera-assisted laser photocoagulations which have been described. And these are certain twins who have been treated with laser and doing well now. This is one of the cases which I said where this patient has appeared much later. The child was 8 years old, and at the age of 8 years, the patient developed this was a regressed ROP where nothing was done. There was an area of avascular retina, and this developed new vessels at the end, so this had to be lasered at that age. The only good thing was that the patient was on regular follow-up, so it could be picked up. Otherwise, it would have led to worse problems if it was not picked up. And there are certain studies where they have done laser outside the need for the same, and this is all. And there was a mention about the nasal tractions which you develop, a kind of a crunch effect which you get from the intravitreal anti-VEGFs. In those cases, there is a tussle whether you have to do a surgery or you do have to do a laser. But if I can wall off that area and I can ensure, because this is on the nasal side, I prefer to do that, because I have seen patients who have been dealt with surgery with this kind of treatment where both the eyes have gone blind. So I would differ on the side of being a little more careful rather than go ahead with a surgery. And if it seems to progress, yes, definitely surgery is the answer. Thank you so much.
Thank you, Dr. Karavi, for the covering of lasers in ROP. We have these topics going to discuss a little more at the end when we have time for discussion. I would like to now invite Dr. Parijat Chandra from All India Institute of Medical Sciences. He is an excellent surgeon who has tremendous experience in ROP, both again surgical and medical management. And I was actually showing him his own article about the whole spectrum of the AP-ROP, beautifully written article. I would refer all of you to read that article to understand about AP-ROP in general. Dr. Parijat.
Thank you, Dr. Kapal, for having this opportunity to be a part of this course. And my respected learned co-instructors, thank you so much. So, I would like to talk about anti-VEGF drugs in ROP. So, we are well aware that anti-VEGF is emerged as a first-line treatment in zone 1 ROP, and it got several advantages over laser, like it allows rapid ROP regression, retinal revascularization. It will eventually lead to better visual field, better foveal structure, and lesser refractive changes compared to laser. Moreover, it is faster, causes less pain, and there is a more stable baby after the procedure as compared to laser. So let's look at some of the current indications where you would like to use anti-VEGF now. So this is typically the scenario. Dr. Anand showed some very nice photographs about zone 1 ROP. So this is how it looks like And for a newcomer coming to ROP, he does not know where to laser, how much to laser, what to do with the macula, should he spare the macula, what to do. So anti-VEGF takes the guesswork out of this picture, and whatever the situation is, the anti-VEGF will work and help this kind of retina to regress. This is what we used to do few years back, and this is what it used to look like, and we should be very happy about it. But now with the use of anti-VEGF, this has become less and less common picture to be seen, and mostly people are using anti-VEGF for this because this had a limitation of tubular vision, poor macular perfusion which cannot be assessed without angiography, and the risk of high myopia. So all these challenges are now dealt with much better with anti-VEGF drugs. Let's look at another indication here. So this is, if you look, the retina cannot even be properly seen in these photographs. So just outline them for you. This is what the retina looks like when the child is examined. So what do you do in such a child? I mean, if you do laser, then where can you do laser in this child? So this is where anti-VEGF comes in, and if you do injection in this eye, this is what it looks like at 6 weeks. So this is the kind of magical growth which anti-VEGF can give you, which laser was never able to achieve. And therefore it is emerged as a first-line treatment in zone 1, zone 1, posterior, ROP and such. So what's the magic in let it grow? So here is another case of zone 1 ROP, another important indication where you can see that nothing much is seen. It's just a clump of hemorrhage and PRD happening at the disc. You can't even see the disc. And obviously it's a zone 1 posterior disease. So what do you do again in this? So you just give an injection and see what happens in the next 6 weeks. You can see the disc has come back, the traction which is there, the PVD has lifted up in that area, and the restoration has gone away, and the retina has grown. So this kind of thing happens again with anti-VEGFs, and they work very well in these kind of situations when you try them. There's another common problem which used to happen in aggressive ROP, where you will find that the pupil is not dilating, and you can see there's extensive neovascularization at the pupillary margin. And in this situation you can't do laser, you can't do surgery, you can't do anything. Although you can see that aggressive ROP is happening behind. So here is again where anti-VEGF can also be useful, and 3 days the pupil can dilate like this. So again, this is magical what happens here, and then once you get this kind of pupil, then you can do whatever you like, and obviously the injection will take care of the aggressive ROP as well. And then you can go ahead and do surgery or laser or anything extra which you want to do in this eye much better than it could be done before. Nowadays we like to combine the surgical intervention with anti-VEGF drugs, because if you see the photograph on the left, you will see that it's already lasered, it's got extensive traction which is developing, and extensive neovascularization is there. So if you go and operate these eyes just by vitrectomy alone, there's a high chance that you have intraoperative bleeding, you have postoperative bleeding, and the outcome right now is not predictable. Eventually you could end up with a contracted kind of retina, or you could have a very severe bleed postoperatively, and the whole thing will just close on itself. However, if you combine it with anti-VEGF injections, then this is the kind of outcome which can be obtained. This could never be obtained by surgery alone. So combining both of these things together can help in selected cases. I'm not saying for all cases, but in selected cases with extensive neovascularization, this can be attempted, and it works very well. While it appears to be a magic drug, and I don't want you to go back with the impression that in all stage for ROP you start injecting anti-VEGFs, because of the important crunch phenomena which is there. So let's say this case is now lifting, laser has already been done. You can see it's a small zone ROP. So this case is right and fit for surgery. So this case was referred to us, we advised surgery in this. Unfortunately, the retinal surgeon wanted to go ahead with injection in this eye, and this is what it turned out in the next 1 week, and it continued to go into stage for ROP. So we should understand that we should not lose the valuable early surgical advantage which is there. Surgery works very well in stage for ROP, but it has to be done in time. If you have a very advanced kind of PRD, then even surgery cannot help fix it. So this is some more growing indications which we are finding more and more often now. So like this case, if you see, again, there's a thick ridge which is there. It's lifting in different areas. There's extensive neovascularization happening behind. So traditionally we laser this, so we are lasering this, but in this we combined it with anti-VEGF. And you can see that thing just disappeared and melted away. This is a post 1 week picture, and you can see the whole thing has disappeared away. Otherwise, what happens in many of these cases where there's a threshold kind of ROP or there's extensive neovascularization, there's a very thick ridge. If you just do laser alone, the ridge continues to lift, because laser needs time to act, and it will continue to lift. So even despite the best of laser or laser plus barrage, it will still continue to lift. Whereas if you combine with the anti-VEGF, this thing just disappears away and makes the outcome more predictable. So next time you get a case like this, so again, I think you should really consider not only doing laser alone, you should keep combining this with anti-VEGF, because I think that these will work much better in this situation than laser alone. Having said that, there are multiple challenges which are right now there with anti-VEGF drugs. Reactivation is a genuine and real problem which happens, and as Dr. Anand pointed out, we should just not stop following up, and we need to continue to follow up these babies for a longer time, 4 to 8 weeks is a critical time when the ROP tends to reactivate because the drug effect wears off. So you have to continue follow up. At the first high index of suspicion, maybe plus disease is coming back, or ridges again becoming neovascular, or flat neovascularization is coming, or it's coming in the area where previously the ridge was there. You need to keep a watchful eye, and then you can do laser, as Dr. Kaur very nicely showed, for areas of reactivation and for areas of peripheral vascular retina, and that will take care of this reactivation. This is unfortunately a very common problem which is happening right now as more and more people are realizing the use of anti-VEGF drugs. We are getting these cases very commonly now being referred to us, and unfortunately it's very difficult to deal with these problems. So cataract is a very important problem which is happening because of iatrogenic lens injury by the needle, and obviously endophthalmitis, a lot of cases are coming to us, and endophthalmitis is a very bad problem to have in such a small eye, and mostly these eyes are lost. So it's very important that we operate, that we give injection in sterile conditions under an operating microscope where it is a more predictable outcome is expected. So we like to inject in an operation theatre where the sterile environment is there, and the OT microscope magnification can be. This is not necessarily GA, it can be done in topic anesthesia as well, but we like to do it in the operation theatre. So should you give both injections together, or should you give them sequentially? So as you understand that ROP is a bilateral disease and both eyes will have a similar kind of progression which is happening. So it's better to give both the eyes in the same sitting. But you have to be careful that the consent is taken from the parents. You understand why you want to do it in the same sitting, just in case something goes wrong, and it has to be treated like two separate procedures. It means, you use separate instruments, you again change your gloves, and if possible you can change the injection as well, and if possible further you can have different drug batches as well of the drug. So these are all some precautions which you can take to deal with this. And as Dr. Gopal very rightly pointed out before, half and half, if you combine, it's like a full dose which is going in. So which drug should you inject? So the literature is full of reports of use of bevacizumab, ranibizumab, aflibercept. A lot of the reports are there. All of them work very well, and all of them show good response. It's just that if I just look at the overall picture, it seems that ranibizumab reactivation rate is a little higher. Aflibercept reactivation rate is similar but occurs a little later. So you have to follow up aflibercept children a little longer. As far as revascularization is concerned, again there is mixed responses there. Some are saying some drug gives better vascularization, some says some gives better. But what we need to know is that Lucentis or ranibizumab has approval of the European Union. The company even says that the drug is approved for use in ROP. So we can be on a safer side if we use ranibizumab compared to aflibercept or bevacizumab because it's got regulatory approval. And just in case you run into any problem, then it's a good safeguard to fall back to. So what dose? So half-hourly dose is what we are using. And but if you will go into literature, you will find again there are many reports which are there which suggest that you can use 1/4 dose, you can use 1 point dose, 24% dose, 40% dose. So all kinds of measurements are there in literature. They say that all of them work very well. They say that if you have got a smaller dose, sometimes the activation is higher. But again, these are mixed reports. Sometimes they say, like the CARE ROP group is I'm quoting, they say that vascularization is better with a smaller dose. But it's difficult to say because again there are mixed reports. From a practical perspective, if I look at it, if I go at 0.12 or 1/4 of the dose, I have to inject 0.0125 ml of the drug, which if you just look in a tubercle lensing will come to just like half a drop of this thing, of the dose. So it's very difficult to give a 1/10 dose unless you've got a pre-filled syringe with a attached needle. It's very difficult to give these small dose. Sometimes the dose might just be stuck in the hub and nothing might go inside. Then again you have to re-inject it again. So all the cost of the injection goes waste if you keep on going smaller and smaller, and we're not sure that the eye quantity was actually injected. So this is just some concern to look out for. So when should we give a repeat injection? This is again a very important topic because as I told you, the drug effect wears off in 6 weeks, 8 weeks. A large number of cases again an aggressive ROP type of picture has started to come back. You can see the leaks are there, the hemorrhage is again starting to happen. So again, if you need fast action, you again need to inject this baby again. Again, laser is not going to work so fast in this situation. And in this situation here, the laser injection already been done. So everything looks to be very nice, and again the disease is coming back. Unfortunately, this is again becoming a very common problem. We used to think that you inject, do laser, and the disease is gone. Unfortunately, that is not exactly happening. If you inject and you do laser, still the disease sometimes tends to reactivate despite that. And since you've already done as much laser as you wanted, now possibly you have to inject again in these cases. And if it keeps on reactivating again and again, possibly you'll have to switch the drug and try. There's a situation where if you can see that even at 12 weeks, a significant peripheral neovascular retina is still there, although the disease is not reactivating. So again you can inject here if you want, and that will allow the retina to grow more. But it's again, there's not too much information in literature about this. And obviously this one is again it's reactivated at 6 weeks. The retina has not grown too much. So if you want, you can go ahead and do laser here. But again you see it's a very small zone ROP which is still there. So if you inject again versus laser, you're probably giving it another chance to grow further. So that's another benefit which is there. So as you see that there are multiple injection issues which are there, how many injections to give? So I think maximum we have given is 5 because the disease refused to come down. Every 6 weeks, even despite laser, despite maximal laser, despite maximal injection, it used to come back. Every 6 weeks like clockwork it used to come back. Finally we have to switch injection. So, but mostly it gets fixed in one injection, and then you can just follow up with laser and it goes away. Sometimes, as I showed you a few case scenarios, you might want to give 2, and then if it still reactivates, possibly better to do laser. Long-term safety issues are there with multiple injections, but we really don't know because literature doesn't talk about it much. Most of the literature talks about safety issues with a single injection. But if you keep on injecting multiple times, obviously it can be a big problem. And as Dr. Gopal said, half plus half can lead to full dose. So basically we are injecting so many times, and what effect it's going to have in the long term, we really don't know. So this is definitely an area of concern. But then if it keeps on reactivating despite laser and injection, then you really need to, there's no other treatment to fix it. When to switch drugs, possibly this is a time when if you inject and it keeps on coming back despite injections, multiple injections, then possibly you can think of injecting, maybe Avastin or Aflibercept if it continues to reactivate with Lucentis again and again. But you need to look into why it is reactivating, So maybe the better way which we found was that if it continues to reactivate, then we tend to do angiography in these cases. If it tends to keep on coming back again and again. Because the retina which we find is growing actually might not be the healthy retina which is growing. And on fluorescein angiography you might find that there's still the capillary network is not as good as the normal retina which is there behind. So then we have to augment these lasers with laser more posteriorly, and then possibly we could bring these under control. So you need to look into it. Why is it reactivating? Does your laser have a split area? Is your laser very scattered? Or is the injection actually going inside? That is some of the concerns are there. So thank you so much.
Dr. Pajak for the presentation about anti-VEGF. 3 points about which are raised about why the lens touch occurs in ROP injections. Probably the risk is more than when you give an adult, because compared to the palpable tissue available, the eyeball is rather large. So space available around the eye is very small and the eyelids are taut. So there's always a risk that the needle can be redirected towards the lens when you're actually injecting. So 2 things you can do. One is of course you use a speculum. Second is a 2-people technique. That is, I usually have an assistant with me and I have the needle, the syringe with the needle in one hand, and also apply a clamp on the needle at a point beyond which you cannot push even by accident. So it's actually like a stop. So the needle cannot go deeper than that because the eyeball is very small, unlike an adult eye. And then I'm using with the right hand holding the clamp, with the left hand I'm holding the syringe, and then going through the sclera. Then my assistant will push the piston. The amount of excursion of the piston is so sharp that it's unlikely that his movement or her movement is going to affect the position of the needle. But by having your both hands firmly on the sclera, you avoid the needle getting redirected towards the lens and avoiding an accidental injury to the lens. And also the solution for using a pre-filled syringe is don't use the people syringe with the needle, take out the drug from it using a 30 gauge needle, and then inject it separately. Then you can even, if you have a problem of injecting 0.025 ml, if that's what you want to inject, you always dilute it with saline and then inject it, so it is easier to inject 0.05 or 0.025 than 0.0125. That becomes even more difficult. Yeah, thank you. Dr. Dogra will be the next speaker. He is going to talk about surgical management of retinal detachment secondary to ROP. Dr. Dogra, again, is a professor of ophthalmology from PGH Chandigarh and has had tremendous experience in ROP. He is a man who described the hybrid ROP, and he has had his experience disseminated across the country by holding multiple workshops and training a lot of the youngsters in this country. Professor Dogra.
Thank you, LG, for the nice introduction. I'm just going to talk something which LG wanted me to talk about the surgical aspect. I have a financial disclosure as far as the buyer and Alargan, being the speaker and at times advisor. When we come to the ROP surgery, I think one must understand it is totally different from the adult retinal surgery. There is going to be a discrepancy in the anatomical and the functional outcome. One must understand that part. And I think we have here Parijat, who has done a lot of bilateral sequential surgery, and I think that is being done also now in my center in Chandigarh, where Dr. Diksha does that. And I feel, I think, because of the anesthesia risk and so many other issues, it is important that if we take two surgeries as totally independent, it's a great opportunity for earlier tackling such problems. And of course, we need to do a lot of counseling, explain the risk-benefit ratio to the patient, obtain informed consent. It's very, very important in surgery, especially for stage 5. Their expectations are very, very high, and we may have just probably hardly ambulatory vision or maybe just a perception. So experienced anesthetists is especially required. I think that is the most important part, because many of them, they can't handle these small babies. And the current surgical approaches in ROPR, I think scleral buckling was the first one described by Michael Tracy. I think it was performed before lens-sparing vitrectomy came in. And the problem was this procedure had a lot of anisotropia, and also at the same time, I think it had a limited application, and you had to remove the buckle because eye wouldn't grow, and you see, because of the anisotropia, there will be other changes. So I think it has really gone down with the advent of lens-sparing vitrectomy, but I must say still scleral buckling sometimes is done. When you have, along with the retinovenous component somewhere, you have a break somewhere, you need to cover that, or peripheral, really, even in a situation where you develop dialysis in a particular situation, I think this kind of a strategy is required. Lensectomy and vitrectomy is mostly reserved for advanced cases. These advanced cases mostly are stage 5 ROP and some stage 4B ROP. And the indications for ROP surgery are stage 4A, 4B, and stage 5 ROP. And we have progression despite laser treatment, or now I will add anti-VEGF treatment. So if you have a progression despite this, you may need surgery in some of these cases, and early surgery. And sometimes we do have a dense vitreous hemorrhage. And bilateral cases especially, we need to be going fast. If you have one eye totally nicely regressed, other eye may have advanced, you can discuss with the patient, it may be okay if you want to do surgery and you feel some benefit can be given. And the lens-sparing vitrectomy, at least to my mind, is the most important single innovation, which is for ROP surgery has proved a boon, because that is where we started going in early at 4A, 4B, and we are able to give them good visual outcome. It's not only we were just trying to preserve their perception or ambulatory vision. And early lens-sparing vitrectomy, I already mentioned, despite laser treatment or anti-VEGF is preferred and gives the best result, and don't delay for it. And this is what is the work of Parijat Chandra and group. If the vascularity is significant, that precludes surgery. surgery, he showed a nice picture also. Then the anti-VEGF need to be injected and early surgery need to be done. And it can also be used per-up on the table. He has even talked about that. So you see, that is the beauty of it. If you do it for 4A, 4B, 60 to 85% of the cases have reattachment. We have a lot of literature, even from our own country here. The recent one being from the Praveen Sen and others from Santa Mitralia. And I'm just showing you a couple of just cases here. This is follow-up of 2 weeks of a photocoagulation case. I wanted to really highlight this point here. If you have something like what you have on the other side where the ROP has regressed, and the other side don't, if you have all around, you have something like 7, 8, 10 clock hours or 12 clock hours like that, it's going to crunch very fast, despite you have good treatment. So don't sit on this. So I'll show you what happened here. So we did a study and published in 2013. So any pre-existing or new onset proliferation after laser, if it is not going away and it is significant, I think this is what leads to retinal detachment. And so is the posterior zone 1 ROP and few other things here. So I just wanted to show you that is the other eye. You see how nicely that regressed because the proliferation was very limited. And you can see that very eye where I have shown, that is the eye, it has gone all to totally, everything has contracted. This is perhaps now even the disc is not available, the whole retina has crunched upon despite good laser. No anti-VEGF has been given here. So this underwent lens sparing vitrectomy and we could open it up and ultimately could be rehabilitated. I'll show you another presentation and very aggressive. Here in such a situation you can't even give anti-VEGF. You give anti-VEGF it will crunch immediately. Now we did laser, but despite laser you can see within 2 weeks it has developed so much of a proliferation, very vascular again. So thought of giving anti-VEGF before, but then again thought it was going to crunch and no chance. So did without, just limited, cut that thing with a lens sparing vitrectomy and left it as such. You can see a good outcome in this particular patient. And this was very, very important because only this eye was functioning for this patient. Some new innovations which were towards the last part of my ROP career in my own institute. One is a stop and slide technique for partial insertion. You see we don't have a special instrumentation for 23, 25 and 27. These are longer. So you just stop at the hub. And that's how if you stop and slide it in, I think you don't reach even if the retina is elevated. So that is something which we have published also. And another one, to me, I've been very fond of lately, all nasal approach for as far as the lens sparing vitrectomy is concerned. This is just to save the lens. Saving lens is the biggest thing. You save the lens, they have a better visual rehabilitation. You sacrifice the lens, they develop everything later on, including many of them develop glaucoma, and you have a visual rehabilitation problem. So that's how, all nasal. So what we do here is just sit on the I'll just show you a small clip. Yes. So in all nasal, you sit on the nasal side, and after you are sitting on the nasal side, then your infusion cannula is going to be in the center. I think during my days, at one stage, I stopped doing totally featureless because I would find vitreous hemorrhage, some of them would leak. So I started making these, and this is what in the center I do. And also, this is the same stop and slide where you don't want to go in. And this, in fact, proved a boon. This even keeps your cannula up. It doesn't touch the lens. And because it is supported by the nasal bridge. And you go for the infusion, for the cutter as well as a light from the either side. So this was a new kind of course we were doing the shifting thing earlier, but we were not really keeping infusion in the center. That part we were doing even. So you can see this is like almost like a volcano kind of a detachment there. And it was almost touching the lens, and you can see how it is like a tent going up on intra-op OCT. So this case, what we do and what I believe in lens sparing vitrectomy is most important is you must clear all the vitreous, whether it is coming towards the lens, going to the periphery, going from the one proliferation to the other, as much as possible. That is the first thing. And then you go in and try to cut all those portions which are safer for you. So if you do that, like here you'll see, now you can see this thick, this thing in the center here. So you have to be very, very slow, gentle, avoid bleeding. You can see the fold going over there. Now I can see there is a blood vessel which is huge. If I cut it just like that, it's going to be a problem. So now I go with the diathermy and try to coagulate from outside because it is, the vessel was much more prominent from the outside. And once that is done, now I can cut it with more confidence, and you don't need to go all the way. You can see the retina is just behind and it is lifted up. If you chase and go overdo, then it's a problem. Now you see it has gone down. You can see intraoperative OCD, the whole thing has settled down. So that is what, now I leave it at this stage and just do a partial fluid exchange, fluid exchange, and just after that I closed this case. So this is what you see now. You can see how nicely the retina would go back and the lens is spared. I already told you the advantages of lens sparing. So I think that is what I did a lot of lens sparing vitrectomy, and this is what was seen at 3 months. So all nasal approach, especially for 4B with temporally we have proliferation which mostly reaches behind the lens. You will always sacrifice the lens. And sometimes it is so, even if you want to rotate what we did earlier, I think Gopal has done such a lot of such cases, so other people have also done, because still sometimes it's very difficult. We have a limited space. This does very well. So I've been if you have something like this going all the way, so the nasal approach, even you can use triamcinolone and remove the hyaloid posteriorly only, and it will go back somewhat and you will have a better rehabilitation. And of course, already the ROP classification has been talked of. I'm just going to talk about this stage 5, which has been included again and re-emphasizing. This is very important from prognosis point of view. If you have an open like funnel, the disc is visible, such a case will do very well with surgery for stage 5. And if you have already, which is called stage 5, disc is not visible, still little rental proliferation is there, maybe it is a closed funnel, they will also do reasonably okay. But if you have interior segment involvement, you have synechry and your chamber is shallow, you have so many other abnormalities, these are the cases they usually we also know they do not that well. I think in the country here, Dr. Gopal was the first one to start this work, surgery for stage 5, and you can see way back 2000 he has published, and only less than 1/3 would settle. Usually they have poor prognosis. Some of them may have ambulatory vision. I think I was somehow not that lucky. I did very limited and very few stage 5. Now, of course, Dr. Diksha is there. She started doing some of these cases which are not really very, very advanced like C, but 5A and B. And I would like to see more and more people also tackling some of these cases where we can still give some ambulatory vision. And of course, here Karobi is there. She has done a lot of surgery. She is another one who is very fond of doing surgery for these children. So lens sparing vitrectomy is something which is the most important, according to me, the innovation, and it has even taken away that role of scleral buckle, which has become very limited. And you can see how much advantage there is of a sparing lens. And if you can do most of the 4A, 4B, I think you have done a good job. And of course, lensectomy, vitrectomy in stage 5, it is required, but we get very late these cases. They have never been lasered. They mostly are 5C, all anterior segment also jumbled up. So they usually will end up into a poor prognosis. But I do, I think even Parijat does stage 5, and so I appreciate all these people. So thank you very much. I thought I'll just give you a little peep into the surgical aspect of these cases. Thank you.
And I thank Dr. Dogra for that beautiful presentation on management of retinal detachment, something very, very complex and difficult for the surgeon and for the parents to accept that this eye may not be able to see despite all your efforts. So the last talk of this session is a potpourri of a talk in issues in retinopathy of prematurity, which I put it out. There are not any specific sequence in terms of understanding or management of ROP, but just some random ideas and suggestions, at the end of which, if you have time, we will have some more questions from the audience. Can I have my slides? Yeah, okay. So the first one is, can one misidentify retinopathy of prematurity? This is very, very important for those of you who are involved in screening, and you may be with the different stages of experience, and you may be the only person around to examine the baby, not having the facility of a second opinion. And you must be rather confident that you have not missed retinopathy of prematurity, because I have had instances where patients have been screened, declared as having no ROP, coming after 6 months with stage 5 ROP. So obviously the disease was missed. So yes, you can miss if a person is inexperienced. If there is a rushed examination due to various reasons, personal reasons, patient reasons, etc., or workload, less than optimum conditions when you are examining, such as a brightly lit NICU. Very often you go to NICU, you are reluctant to ask the nurses to switch off the lights. And a bright lit NICU when you examine, there is a chance you can miss findings. Improperly positioned crib, the child is positioned at a very high level crib, which is not brought down to your height. Then again, your examination is in a very inconvenient posture, you can miss findings. There are cheats all around the infant, which you are afraid of displacing because you are worried you will affect the child's oxygenation, etc., etc. So it's very important that the trained nurse or the pediatrician must be available with you to facilitate the proper exposure of the baby for you to examine properly. So you should not compromise on the examination just because nobody is there to help you with the baby's positioning. A very unstable infant, there is always a pressure on the ophthalmologist that quickly finish out the examination, otherwise his oxygen saturation is going down. Well, yes, then in such cases you use an experienced examiner to examine and not allow the budding pediatric ophthalmologist to examine the baby. But yes, a quick examination is important, but when in doubt, always re-examine when the child is a little more stable. Inadequately dilating people is a big problem, which we can counter by many small maneuvers. Screening with poor quality pictures also is a reason for missing and identifying ROP. And if you are in the center, which is away from the site where the child is being screened, and you are examining, say, 30-40 images in one day, so there is a tendency for labeling those gray areas as, okay, probably it looks normal, and you can actually miss ROP. How do we safeguard against missing ROP? A final examination before declaring the child as not requiring a critical follow-up, and a clearance must be given by an experienced examiner, even if the initial screening is done by a less experienced person. And that is after physical examination with indirect ophthalmoscopy and indentation, and not just by telescreening. Now you should also create the right conditions for proper examination. I don't have to emphasize that again and again. An unstable infant I already told you about, and when in doubt, re-examine the infant in a short interval, that is after 3-4 days, rather than waiting for 2 weeks thinking that there is no ROP, I examine after 2 weeks. Concentrate, again, when the pupil is a little small and you have difficult examination situation, where the child is really sick and lots of tubes around the infant, examine first the temporal periphery, because the likelihood of you picking up ROP is highest there. There is a beautiful study by Dr. Benisara from Israel, which showed that in many cases, if the temporal periphery is fully normally vascularized, the chances of a nasal ROP is extremely low. The difference is in a zone 1 disease where you can get nasally severe ROP even if temporally there is no severe ROP. But in a zone 2 and beyond vascularization, the chances are that you will get only in the temporal periphery disease and not nasally, or temporal plus nasal but not only nasal. So in temporal periphery you spend a lot more time. It's actually easier to examine and indent and make sure that the vascularization is all the way to the periphery. then even if you cannot examine nasally properly, you can be reasonably certain you are not missing ROP. Managing inadequate people, you can use a 30 diopter lens. It can allow you to examine to smaller people. And you can indent that itself produces a little bit of induced dilation, even that 1 millimeter dilation is adequate sometimes to get an idea as to what is happening. And small people ophthalmoscopy, many people don't tend to use a small people ophthalmoscopy. That's extremely useful. By adjusting, I'm not sure the Indian-made ophthalmoscopes always have a very good small people ophthalmoscope, but something like a Welschalin or a Keeler has a beautiful small people ophthalmoscope attachment, wherein by adjusting the IPD as well as the spot size, you can see through even a very small people enough to know that there is ROP that needs treatment or not. And in doubt, you start them on topical steroid and re-examine after 2 to 3 days. Usually the people tend to dilate. In the worst case, of course, is there is ROP identified, but you don't know how to stage it or you can't examine because there is so much of small people, you know how to inject anti-VEGF and then re-examine them. Dilation for ROP eye examination, also called ROP, has its own issues. One is use of cyclopentolate. In most countries, the midrim, which is meant for ROP dilation, has cyclopentolate with phenylephrine. Well, most of us here tend to use tropicamide with phenylephrine. But cyclopentolate is known to be associated with gastric emptying problems and intestinal emptying problems. So these infants can develop intestinal distension, abdominal distension following use of cyclopentolate. So we see the significant blood levels of cyclopentolate are associated with gastric residuals. And people have tried alternative dilation methods such as Midria set, as seen in the photograph to the left. There you can see the pictures are of a Midria set, which is nothing but a small pellet which is soaked in the dilating agent, which is kept in the conical fornix. It releases slowly and the amount of drug that is eluted is much less than what a drop is, and plus most of the drug is acting on the eye and not getting absorbed into systemic circulation because it's not going into through the nasolacrimal duct into the nose. And there are people who have used something called micro drops, which is actually in a particular study they have used a pipette, a glass pipette to put the drops. The difference is a regular drop is about 40 microliters and the micro drop is only 3 microliters. So the amount of drug you are actually placing on the conjunctiva and on the skin, which also is a spillover, and through the skin also it can get absorbed systemically, and that is very, very minimum. I'm sure in the future we may get dispensers with micro drop dispensers for use for ROP. And other studies which have used vaporized tropicamide application where they applied on the mid-margin vaporized tropicamide and found that it is equally effective in dilating the people with very little drug being actually coming in contact with the child. And of course most of us advise dilation, go and come back for 40 minutes to 1 hour to examine the baby. We are not bothered that the neonatal nurse who puts the drops does not follow punctal occlusion at all as a regimen. So it is something we should insist upon so that the drug is not unnecessarily getting absorbed systemically. Inter-observer variation interpretation is another important issue I thought I will highlight. In a study in 2016 by Campbell, out of 1,553 eye examinations where they compared indirect ophthalmoscopic evaluation with an image evaluation, both same time taken webcam pictures which were evaluated later on. There is only 40% agreement, there was 40% disagreement in the staging classification. Even stage 1, 2, 3, there is a confusion. The confusion is mostly between stage 2 and 3 rather than between stage 1 and 2. And there is 18% disagreement in diagnosing plus disease, including pre-plus. Pre-plus itself is a gray term. Pre-plus is nothing but when you are not sure it is plus, but there is some dilation you are calling it pre-plus. So that itself is a gray area. You are making it even more gray by saying there is 18% disagreement even in calling it as a pre-plus disease. And there is 8% disagreement in zonal classification, the zone 1 or zone 2. But the study in general has shown that there is a 90% agreement in calling it as a type 1 disease which needs treatment. So that perhaps is a good point to understand that in most cases we probably agree on when to treat, although we are not very sure that there is a precise stage and precise plus disease. Now, Flick et al. Have shown as a part of a BOOST 2 trial, which is a trial being conducted between United Kingdom and New Zealand, where they compared the ophthalmologists in New Zealand versus gray areas where we can differ in our opinion. And when you do differ in opinion, there is nothing wrong in taking another opinion from your own colleague. Or, when in doubt whether to treat or not, see them very quickly in 3 to 4 days time and then treat them. And when still in doubt, and in a country like India where follow-up could be an issue, you err on the side of treating rather than waiting and watching. Now coming to APROP, there is also confusion with diagnosis. We all know that the description that is described by flat neovascularization compared to elevated neovascularization, which is a hallmark of stage 3 in ROP, in the classic ROP, or so-called CROP in contrast to APROP. It occurs in zone 1 or posterior zone 2. It's got a severe plus disease, large vascular loops with no capillaries within the loops. That is, large vessels have developed, but there is no capillary plexus within the loop. And there is usually evidence of retinal and vitreous hemorrhages because these vessels tend to bleed under the influence of the high VEGF content in the vitreous cavity. Usually it affects extremely premature babies, but it can also affect relatively large babies in developing countries where oxygen administration is mostly unmonitored, and is usually associated with sick babies, sepsis, and thrombocytopenia. This is a study, beautiful study that Anand Vinekar, which showed that thrombocytopenia is associated with the occurrence of APROP more often, and they have shown also that multiple episodes are more commonly associated with this event rather than a single episode. Or episodes which are correctable by platelet infusion probably are less at risk of APROP than those which are not correctable by platelet. Despite platelet infusion, they develop persistent thrombocytopenia. And chorioamnitis is also described to be associated with APROP. However, we have seen from the description of Dr. Dogra that there are hybrid varieties. Means in the same eye, you can get parts of the fundus showing pictures of flat neovascularization consistent with APROP and parts showing a ridge consistent with classic ROP. So that tells you that it is not again a single disease or yes or no. It is again a spectrum which can merge from an entire APROP to hybrid variety where the amount, the component of classic ROP can vary, and the amount of component of APROP can be correspondingly variable. So the more the classic component, the prognosis is better. As has been described in heavier babies as well and described in zone 2. And extreme forms of course pose no difficulty in diagnosis. But this is a picture I lifted from a publication from the course on ROP by London School of Hygiene and Tropical Medicine called Future Learning. In this they have shown 2 pictures which can be confused, not exactly identical, but they can be confused as APROP. But the picture to the left is APROP, which tremendous dilated vessels, vascular loops, and tremendous amount of retinal and vitreous hemorrhage. While the picture to the right, if you see very carefully, there is a ridge formation here. And this ridge is what is setting apart this from APROP to classic ROP, stage 3 plus. Coming to treatment, again Dr. Karodi beautifully mentioned about the difficulties in treating the entire fundus properly. So very often there will be missed areas. You think you have done an excellent job, but see them again a week later you find large areas of untreated retina. Because as you treat, the cornea becomes edematous. If you keep hydrating the cornea becomes, and you keep pressing the eye with the indenture, the cornea becomes edematous. And because of edema you can't see the fundus properly, and you keep treating areas which are obviously visible but which are not obviously visible, you tend to miss. And 2 meridians which are consistently missed are at 6 o'clock and 12 o'clock. So how you avoid missing it? The ideal position for treating that is, as Dr. Anand Vinekar explained during the examination, is stand diametrically opposite to the meridian. So if you keep turning the baby, what I usually do is place the baby on the crib. I stand in one position, but keep rotating the baby so that I can reach all meridians. And sometimes of course go on to the opposite side, again rotating the baby. So while rotating the baby, you keep the treating area exactly opposite to your direction. Otherwise, number 1, you crane your neck, is bad for your neck over the long run. Plus, number 2, the spot is not perfectly circular. You know very well there is always a scattering effect of the light when you make it as a large spot. So the best burn is the smallest circular burn. You get the concentrated energy, you get burn with the least energy on the machine. Otherwise you keep on raising the power unnecessarily, and suddenly you get a very heavy burn because you are able to make it a small circular spot size. So that is the ideal endpoint. And also see how many shots you have fired and how many you're actually seeing inside the fundus. There's no meaning in trying to say I am very good at it and keep it at 100 millisecond interval between two burns and keep on firing and hoping that some of the burns are going to hit the retina. That's a very wrong approach. What you should do is keep the interval very long, even 600 milliseconds, and deliberately focus each burn and treat it. Doesn't matter if you take a little long time, but you're actually wasting less of laser. And don't think a laser burn which is not registered on the retina is wasted in terms of the damage it can cause to the eye. It can heat up the eye unnecessarily, but it's not causing any burn. And there are cases reported where an inexperienced surgeon, inexperienced person has treated both eyes, and both eyes developed the next day dense cataract because he has heated the lens so much more than what is required during the treatment. And non-dilating people, as I said, using pterodactyl lens, you can actually produce some amount of treatment. Indentation should assist some dilation. Treat posteriorly first as much as possible because that's easily treatable even through relatively undilated people, and give some time, 3-4 days, and I'm sure the people will dilate because you have treated something at least. Anti-VEGF is not possible at all. Follow-up of post-injection of anti-VEGF has been touched upon again by Dr. Parjat, and he told you in detail how to follow up these patients after giving an anti-VEGF injection. Now, nothing is certain about how frequently we should follow them up. Is it every weekly, every 2 weekly, or every monthly after a point of time? And if no recurrence, but persistent avascular retina, what do we do? Yes, in general people say that if it is less than 2 disc diameters from the ora serrata, the amount of avascular retina, the chances of that child developing a recurrence is very low. But if it is more than 2 disc diameters, beyond the point when the child becomes difficult to handle, it may be easier to treat extreme periphery because you don't lose too much of peripheral visual field by treating 3 disc diameters from the ora serrata, but you can sleep in peace after that because the child probably will never develop a recurrence. Less of the issue of inadequate examination of periphery, because as the child is growing up, you can't even indent the periphery properly. Unless the child is also developing incidentally a prematurity related myopia. I have one child where the eyeball is becoming a little larger and larger. So I didn't have to really indent much. I can see the periphery quite well. So that is not something you desire, but something that can happen. But in general, as the child is growing up, it becomes more and more difficult to examine the periphery. RD in periphery, is there still a role of buckle in stage 4 and 5 RD? Yes, in the past we used to get most patients untreated and unscreened. So there are many cases which used to be responding to just putting an encircling band. When the posterior pole is still relatively shallowly detached, you put an encircling band, despite peripheral fibrosis, some of the remolding takes place and the fibrosis settles down to some dry folds but mostly attached retina. So that is better than needing a surgery. But these days, when you screen them properly and treat them properly, still if they need surgery, it's mainly because of severe disease which produces a posterior pole TRD rather than a peripheral little detachment. Those cases are not amenable for buckling. You need a lens sparing vitrectomy as well, immediately by Dr. Dodra. But there are occasional cases where they can come to you, relatively heavy baby, 1800 grams, 1900 grams, who has never screened and developed ROP late on. In fact, there is a student I operated on one child like that. One eye was amenable for a buckling. So I did actually put an encircling band in that child. But these days, I think the number of such cases are far few in between. Now, do we operate on eyes with fully formed falciform fold? Doesn't make sense to me. Because whatever you do, the retinal synucleus cannot be released. So you have to understand that once the retina is stuck right from the anterior limit or ridge, knife edge, to the posterior limit at the RPE level, it cannot get opened up. So there is no meaning in operating on those eyes. In fact, the area of peripheral attached stretch retina has function in it, and very often they are having mobile vision. With low vision aids, they can be helped. So fully formed falciform fold. By fully formed, I mean retinal synucleus right from top to bottom is not an operable situation. But if it is still a tent, it is not formed a fold, then you can probably try to release the traction and hope that tent of detachment can settle down. Now, under what circumstances would be willing to try a second surgery? After one surgery for stage 5 ROP, in general we can avoid it because success rate is very low. But where the retina has gone back significantly and with a little bit of residual traction, we tend to go back again. If break forms during VR surgery, is there a role of tamponading? Again, very occasionally, I have had at least 2 patients in my entire career where I could remove all traction, put silicone oil actually, and remove the oil, and the child still has useful vision. But these are 2 cases out of hundreds of cases I have done in the last 30 years. So that tells you that it's extremely rare that in stage 5 ROP or stage 4B, you can have attached retina, and then you can have an opportunity to do internal tamponading after removing the preretinal tissue. Thank you very much for your attention. So when we finish the formal presentations, we'll be happy to take any questions for discussion. I heard that there is no other session after this in this hall, so you are free to ask as many questions as you wish to.
We discussed medical legal aspects also, like how to note down and what not to write, what to write. We can, I think we can get a highlight.
So I did put a little bit of that in my presentation. The 6 cases that have gone against the doctors here in India, from there we derived what would be the best ways to avoid possible litigations for the ophthalmologist, for the pediatrician, and even some sort of contributory negligence from the parents. So the main thing, of course, is to follow to summarize it, basically we have to follow the most current national guideline. If there are 2 guidelines, one from a society and one from the government, and then even if the government one is slightly older, we have to follow the one from the government. So that is one of the legal caveats. And they mean that the NNF guidelines, which is a prominent society, has come up with the 2020 guidelines, but that is still a professional body, and the older Government of India guidelines which came out in 2018, that is still a government guideline, so that is the one that needs to be adhered to, because that's what the court will look at. If there is no guideline at all, then a professional body was still okay. The second one is in terms of the funneling of these babies to the ROP specialist from the pediatrician. It completely is their responsibility until they refer the baby to you. So although morally we can go into the NICU on a fixed day if we have chosen, and you can go around and say, okay, this baby is eligible for screening. At the end of the day, until the pediatrician or neonatologist sends these babies to you for the screening, it is not your liability. And I'm talking only from a legal perspective, not from a moral or a clinical perspective. The documentation that you do, as I mentioned here, if the patient is admitted inpatient, then you must have that duplicate record in the inpatient file, because they have doctor progress note, nurse progress notes, as we have all seen. Dilatation, which drop you used, how many times you used, what method you used for examination, have to all be mentioned, and this happened after the Lucknow and the Delhi case, where the court mentioned that they accused the doctor of falsely saying that the screening was done on time, because somewhere inserted in between one day and the next day was ROP screening done, no ROP noted. That is considered inadequate evidence. So one has to mention, because the dilators are a drug, and every single drug used in the NICU is documented in the nurse's drug sheet, the fact that the drug sheet did not contain the dilatation regime was held against the pediatrician. Said, where have you dilated? You've just written ROP screening done. The next thing is which instrument. So indirect ophthalmoscopy with 20 diopters, we all do that. We assume that that's what it is if we are not using imaging. How many of us document that on the inpatient file? So that's another thing we learned. And then of course this whole no ROP, yes ROP thing has to go. Either you, as a new classification, we need to follow immature blood vessels reaching immature retina up till zone 2 anterior, and 2 weeks, 2 p.m. Thursday in the NICU, in your outpatient or wherever. Certain interesting scenarios have developed from a legal perspective, especially if your patients are NRIs and they have an American background. They write the month first and the day next, as we know from in the US when you follow any US system. So 5th of April, 4th of May, for example, and 5th of April would be interchanged. And you can imagine if you have called a baby on 4th of April and they've assumed it as 5th of May, and they come a month later, the child could have been blind by then. And this has actually happened to a very senior person in the country. where they've mentioned 4, 5, and 5, 4, and they've come instead of April, 5th of April, they've come on 4th of May. So in these rare scenarios, it is better to actually write 5th of April or April 5. The other thing that we have learned from a legal perspective is whenever you are doing, these are small things but important legal things, when you write, again same example, 5th of April, always write 0504. Because if you've not put the 0 in front of the 5, tomorrow if somebody can put a 1 or a 2 against that 5, and you would be wrong. They would say you called us 2 weeks later. Even if there's contributory negligence, the fact that you've called them on a time when it should have been called earlier, then that would be a problem. So always use 2 digits even if you're dealing with single digit numbers. And I think that's as far as the documentation goes. Consents have to, there is no ideal consent, and in law you don't actually have to have a written consent, believe it or not. But as the court cases are being heard against and for, your safest bet is to have a written informed consent, ideally in the language of the patient, which is hard many times. So what one does is that you can have a standard format, add in a few handwritten sentences such that I have been explained in my language, or let's say the standard consent is for a classical ROP, but now you've gone on to aggressive ROP and you don't have a special consent, and it's high risk now, or they have come late. All of that add as handwritten sentences between your typed out paragraphs, and you initial on the side, and you get the patient also to initial on the side. Another popular way of doing it, foolproof legal method other than a video consent, is to have them handwrite one small sheet saying, I was explained the consent sheet attached with this form, which of course they have initialed and signed, in my language, and I have cleared all doubts. So that one paragraph, if they are literate enough to write it in their own handwriting, super. Otherwise, again, you can write it in the vernacular and get them to sign it. These are, as I speak to lawyer friends and pediatricians in law, this is not yet standard of care, but I think it's good to exercise these things as we go forward.
I think there is one more thing that when we call them for a review, we write like this, that the strict review on this. We just simply don't write that review, or like Punah Parikshan Karna, very strictly or strictly were to be used. And one note we can make that if in case your inability to come or inability to get the retinal checkup done, complete blindness may be a possible.
Absolutely. So these are the sentences our teams use because, of course, in this case, the non-ophthalmologist is screening. So explain the risks of prognosis and requirement of thing, if does not come on time, can lead to permanent irreversible blindness, has been explained.
In one case, I think they have mentioned, the court has mentioned that the severity of non-turning up was not explained.
Correct.
One last thing, that how safe we are medical legally in injecting these cases with Avastin?
So I think we are safe. The fact that it is being used, it is now, ranibizumab has now been accepted by DGCI for ROP use itself. That is something that we are safe. The indications are out there, the consents are out there, the VRSI has a consent for, okay, albeit for adults. All of this is accepted. And at the end of the day, when there is a gray zone, even a wrong diagnosis, a complication, a medical error is not medical negligence. This is the main thing that we have to understand. We are fearful that, oh, if I've got the diagnosis wrong and I've treated wrong, I'm negligent. No, you are not liable as long as you followed the standard operating process. You are not liable for injecting if it was not supposed to be injected. Morally, clinically, you may be wrong. I'm only now speaking legally. So we don't have to worry as long as we have followed that. As sir said, bilateral injections, right? Now, if VRSI does not recommend bilateral injection for adults, if you are doing it in good faith for the benefit of the patient, document that. Document that calling the baby back in for a second injection, even if it's the next day, why you have not done that, what your risks you've explained, and get it signed. And that is how you will be safe.
There is just one point I would like to add to what Anand has explained, is that when you specifically patients like this where you suspect that if you don't see the patient on the appointed time, you can actually miss a window of opportunity to treat. It may become a responsibility of the ophthalmologist to have a system in place where if the patient does not come, they are called. And we document in your findings that I have called the patient, but the patient did not respond. At least you have fulfilled your side of the responsibility. despite one or two calls, each call is registered in the electronic medical record. That yes, patient has been, we tried to reach them, made 2 calls, 3 calls, there was no response. Then at least you are not at fault. But you should make an attempt to reach the patient, especially when these are cases where the window of opportunity is so important.
So if I may add to what already has been said, especially when you're taking a surgical consent, you have to mention what you have prognosticated to the patient and the possible chances of disfigurement of the eye in case the person's surgery doesn't work out, because that also becomes a very important kind of issue in these conditions.
I have a question on cataract following intravitreal injections. So most of the time I have observed with the trainees and especially in eyes, when because of the balls, the eyeball rotates up and the direction of needle is mistakenly given inside the lens. But despite that, I noticed in one baby where the technique in the breathing was okay, but the cataract developed around 2 weeks later. It was in the form of we see the pearl type of PCO. So the water vacuoles in the posterior capsule of the lens. So that is a bilateral injection developed in both the eyes. Anyone has observed this and what could be the reason? It is not that needle track type cataract that we see.
No, I have not seen.
I don't think I have seen, you are talking about a vacuolation inside the lens, but the capsule is intact.
Yeah, so that was there, that was not there during injection. But
is it at the same meridian as injection or no, different meridian?
So it was both inferonasally and inferotemporal.
Then obviously it's not due to the needle touch, it is just something which was occurs due to other reasons, right?
Yeah, this was not there on the day of injection, because after injection we examined the babies under the
I agree, but other disease is not associated with the needle touch because it's not in the same meridian and somewhere else, and you are sure the PC is intact even afterwards. So you're talking about, is it a reaction to injection? I don't know.
Maybe just the child is developing a congenital cataract along with the ROP. That can explain the vacuole which are coming in as a routine.
I think they want us to conclude the session, so maybe we can continue the discussion over a cup of coffee outside. Any of you interested in discussing with the galaxy of stars here on the stage, please talk to them and learn from them. I'm afraid they are asking us to leave, otherwise probably they may come with a stick and beat us out also. Thank you very much. Thank you very much. I would like to thank all the speakers for their excellent presentation. Thank you.